Hello, everyone. Welcome back to Neuro Spicy Nursing. This is a kind of micro mini lecture on DIC, like I promised, and how it really works in OB. It's going to be a little bit different than that med search DIC-ish, kind of, because the causation is different. We'll get into it. Okay, so DIC stands for disseminated intravascular coagulation. It's a condition where the body forms tiny clots everywhere. And by forming those tiny clots, it's using up all the platelets and the clotting factors. So once those are gone, the patient starts to bleed uncontrollably. And so DIC is basically you're clotting and you're bleeding at the same time. So in obstetrics, one of the most common triggers for it is going to be a placental abruption, severe preeclampsia, or HELP syndrome. Amniotic fluid embolisms, sepsis, and retained placenta from placenta or retained dead fetus can also cause it. Remember that DIC is always going to be secondary. It's never going to happen on its own. So that's why we have all those different causations. Here's a little bit of the simple pathophys of it. I kind of just talked about it. You have a trigger, massive clotting activation, platelets and clotting factors are getting consumed. Your body's going to run out, which is causing you to uncontrollably bleed. And then those microclots can also cause organ damage because of ischemia or because the uncontrolled bleeding can lead to poor perfusion. All right, so some clinical signs is you'll see oozing from IV sites, their gums, any incisions. You may also see petechiae, low fibrand. They may have a prolonged PTINR, a PTT, or an elevated D dimer. Nursing priorities are going to be treat the underlying cause. We're going to replace blood, any clotting factors. We're going to monitor for shock, make sure that we maintain oxygenation, and prepare for the possibility of an ICU transfer. These are all the different lab values that you want to monitor: platelets, fibrinogen, PTINR, APTT, or D dimer, and you especially want to monitor kidney and liver function. Kidneys, especially because we have poor perfusion, we end up with a acute kidney injury, right? That can be affected. So look out for that. There are maternal risks like hemorrhaging because of when all those clotting factors are used up, obviously we can hemorrhage. We talked about the multi-organ function, hypovolemic shock, obviously all that bleeding, right, can cause hypovolemic shock. And then if it's left untreated, it can lead to death. There are fetal risks like hypoxia because of the poor oxygenation, poor blood flow, preterm delivery, and then fetal demise, especially if there is a placental abruption. And then a little note, again, remember DIC is clotting and bleeding at the same time. It's always going to be secondary to something else. In med surg, DIC is normally secondary to sepsis. DIC in OB is normally secondary to a placental abruption. Fibrinogen is going to be one of the most important labs to make sure that you're monitoring, along with the H&H hemoglobin hematocrit. Again, abruption, number one cause, and then oozing from any sites is going to be an early sign. Also remember that DIC is life-threatening for both mom and baby, so early recognition is critical. These are the resources, and thank you guys. That's all I have for you. And yeah, that's it. Have a good day. Bye.